Hello from wherever you are, and welcome to Oncology for the Inquisitive Mind, the podcast that aims to discuss, dissect, and demystify the frequently confusing and always fascinating world of cancer and cancer treatments. I'm Michael Fernando, and I'm joined as ever with my co-conspirator in this podcast endeavour, Josh Hurwitz. How are you doing, Josh?
Yeah, good, mate. How are you today?
I am just peachy. Today we've got something a little bit different, something that is less common, I guess, than colorectal cancer or lung cancer or breast cancer, and that is a cancer that is quite common. If you can believe this, Josh, very common in our home country of Australia. We have one of the highest incidences of this particular disease. This particular disease is mesothelioma, which some of our listeners might not have even seen.
It's not that common, but unfortunately, over the better part of half a century, I think you could say certain companies and exposure to certain agents really led to this being a big issue with limited options.
Yeah. Well, I think we're being quite cagey about this now, so let's dive into things. We do anything here on Oncology for the Inquisitive Mind to keep up the aura of mystique, but let's peek behind the curtain, the mesothelioma curtain. So first, a bit of background. So mesothelioma, as Josh was heavily implying moments ago, is a disease that is associated with exposure to asbestos, fibers, or asbestos dust. And I think some of our younger listeners might be a bit too young to remember the whole controversy surrounding this, particularly in Australia. Did you know, Josh, that asbestos was only completely banned in Australia in 2004?
Which is nuts when you think about it. And even scarier is this is actually still commonly used in many overseas countries.
Yeah, exactly. So you have... I always had this impression that it was a remnant of the past, Josh, of your early childhood. In the
I'm an old man. That's what everyone just understand. I'm a very old man. I just sound slightly younger than I am.
Absolutely, yeah. As I remind you every day. So,
Thank you.
Asbestos exposure to asbestos dust and fibers, but the nasty thing about mesothelioma is it's very insidious. So it frequently arises decades after someone has been exposed, obviously, by which time it's too late. It typically, as a result, affects patients who are 60 years old and over. In Australia, according to recent statistics, the highest incidence, and this probably reflects patterns of asbestos use, the highest incidence was in patients aged 70, 75, 80 years old. In 2018 in Australia, there were between 700 and 800 new cases per year, which, in the grand scheme of population is not huge, but it's still very, very significant, still a very significant disease. Thankfully, at least in Australia, the incidence has appeared to peak around this time, around 2018, and subsequent figures have shown that the incidence is starting to drop, which, of course, comes with the causative agent being phased out. Josh, what would you say the most common trade that was exposed to that comes with a risk of exposure to asbestos is on our medical history? When you're talking about previous occupations, what would you say the most common is?
I probably think like a builder or a renovator or someone that does plumbing, all those things where, you're ripping out internal sheets from housing or even buildings. So I think, and Mikey, correct me if I'm wrong, but asbestos in a solid form is relatively safe. You're unlikely to breathe in the particles, but when you kind of crush it up or cut it or break it in any form, then it's, you only need one fiber. That's all you need. And if unfortunately that's the fiber, that could be the fiber that causes you to have mesothelioma.
Yeah. I think it's sort of talked about in similar ways to smoking. We say there's no safe minimum number of cigarettes to smoke.
There is one. It's 0.
Well, yes, yes. There is no safe minimum number of cigarettes above zero. Same thing is with asbestos as well. So you're absolutely right. Builders, plumbers, electricians specifically, which leads to the question: why in every MCQ is it always the poor boilermakers that end up getting mesothelioma?
I feel that they must be really old questions because, like, I don't know, Boilermaker.
How many proud boiler making businesses do you see these days?
I mean, ironically, I always imagined a Boilermaker as someone in like 18th century United Kingdom that's like building those like big heaters in the
Mm.
basement of these apartment complex. I actually don't think that's what a Boilermaker is.
I'm
They
I'm sure we're going to get many complaints from the Boilermakers Union of Australia about how we're misrepresenting their trade.
fair enough.
But anyway, so mesothelioma affects patients who have had certain trades. I mean, there's also obviously risk of residential exposure if you are in the house that's having the work done. So you can get exposed that way. So it's not a hard and fast rule. And it's associated with a very poor prognosis. And in previous episodes we've talked about the idea of if you have an early cancer that can be cut out, then your prognosis is better. That stands to reason. The thing with mesothelioma is that it is a very, very small minority, small even by oncology and oncological surgical standards, of cases that are resectable. I don't think I've ever seen a case of mesothelioma that has been resected and recurred. Josh, have you?
I have not.
Not generally something that we see. And so today we're going to look at two studies in the area of mesothelioma. One is old, from 2003. The other is much newer. But I guess a a bit of window dressing, as we always tend to do on this podcast. So you have a patient who, as we have said, is 75 years old, let's say, he's a former Boilermaker, big burly man who's impressive in every way. Don't sue us, Boilermakers Union. And he comes to you sort of saying, look, I've got increasing shortness of breath. I'm very, very fatigued. I've got this chronic dry cough. And, one thing leads to another, and he is diagnosed with mesothelioma. The
Hmm.
subtype is important, as which we'll come to talk about soon. But he has unresectable, as is always, metastatic mesothelioma. Um, it's the other thing to mention, I guess, before we jump into this is mesothelioma is n- frequently, but not always, a disease of the lungs. I have seen sort of abdominal mesothelioma, abdominal primary mesothelioma. I've seen it once. But typically it is a cancer of the pleura. Um, Josh, you're about to say something.
I am. And one little fun fact of the day for Josh is that this is obviously a US paper, but I just wanted to bring it up. So until October of 2020, chemotherapy has been the only approved first line treatment for metastatic pleural melanoma since 2004. So, guys, what that
You
means
mean
is that they're.
mesothelioma?
What did I
As
say?
you said, pleural melanoma.
I meant mesothelioma. Oh
That's a
my
different
goodness.
podcast, Josh. You're living in the past.
I am living in the past, and obviously that's fine. So, just to clarify, mesothelioma, there was 16 years, guys. So 16 years between any change in treatment, and for someone who has mesothelioma, look, that's you know, there's no way they'd reach from A to B.
We're going to talk about that chemo study that you mentioned. And you're absolutely right that from that until 2020, this was really the only advance that had been made in mesothelioma. So uh, very unfertile, what's the barren ground for studies and evidence. So this is a study made by, and I'm going to completely butcher this name, apologies, Vogelzang et al., Vogelzang and Associates. It was published in 2003. And it was comparing cisplatin chemotherapy, platinum-based chemotherapy, with or without what was at that time a very new chemotherapy, pemetrexed, which is a antifolinic antimetabolite. It enrolled patients who had had unresectable confirmed mesothelioma, who had been previously untreated. Patients had to have a life expectancy of greater than 12 weeks. The average, I think, around this time was about 6 months. They had to be over 18, obviously. It's very difficult to get mesothelioma when you're younger than 18. I'd love to see that. They had to be good from a functional perspective. They had to be able to keep chemotherapy or tolerate chemotherapy, I should say. And they couldn't have disease in the brain, which, again, I haven't seen. Josh, have you ever seen CNS metastases to from mesothelioma?
Look, I haven't, and I wonder why, because it's such a terrible cancer that maybe the actual sequelae of having the cancer is so fast that it doesn't get to a point where it spreads to the brain. It's
Yeah,
just
the pancreatic cancer syndrome. Something else gives before it has a chance to get to the brain.
unfortunately, yes. And Mikey, with all the patients that we've seen with mesothelioma, these have been really active, healthy, people that come in and they've just shed kilos and they're cachectic and they're skinny and they're just at a point where, because it's such an insidious disease, they get there like, Josh, I can't breathe. I don't know what's going on.
Yeah. Um, so we've got in terms of this chemotherapy study, we've got a comparison of two chemotherapy regimens. The primary endpoint was overall survival, and the secondary endpoints were progression-free survival, time to treatment failure. So, when in practical terms the treatment actually stopped working, overall response rate, and duration of response. The median age was 60 years old, as is frequently the case with mesothelioma in the real world. 81% of the patients were male. As Josh said, over half of them had a Karnofsky score of greater than 90, so very, very fit, very active. In terms of the subtype, which I might as well just mention now, the close to 70% were epithelial, which is the subtype associated with a, relatively speaking, of course, better prognosis. Of I think there was a less than 20% of patients had the bad subtype, which was sarcomatoid, which I know Josh will talk about with his study. And the almost over 3/4 of patients had stage 3 or stage 4, so as mentioned, unresectable. The results, in comparison and contrast to our recent melanoma study, this makes for very grim reading. So the median overall survival was 12 months in the patients who got cisplatin and pemetrexed, and that was a huge improvement, relatively speaking, because the patients in the control arm had a median overall survival of 9 months. I think that just shows how bad this disease is. That I'm sure people were jumping up and down for this 3 month improvement in overall survival. The 1 year survival in the cisplatin pemetrexed group was 50% versus 38. Progression-free survival was almost 6 months versus almost 4. The tumor response rate, this was much more impressive, was 41% versus 16%. And if you look at the Kaplan-Meier curves, all of the patients were almost all passed away by the age of by 15 months after enrollment. So if you look at the Kaplan-Meier curves, they are pushing zero by 15 months. So there's almost no survival, which again is very grim. So that's really, I don't really have too much to say. I think on this occasion I've drawn the short straw. We try and keep it even here because Josh drew the short straw last time. But this as sort of grim as it was the standard of care for almost 20 years for mesothelioma, and largely due to the fact that there was nothing else. Now, practically speaking, and Josh, please chime in if you've seen something different.
Will do.
But as you always do. But in patients who, for whatever reason, don't get immunotherapy, which is the subject of your trial, I've seen more frequently patients get carboplatin, which is similar but different platinum-based chemotherapy with different toxicities, than cisplatin. And in my reading for this episode, I couldn't really find a good amount of data or robust data for use of carbo pemetrexed as opposed to cisplatin pemetrexed. All I could find was small phase 2 studies. In the real world, are you seeing more people get carboplatin against cisplatin or versus cisplatin?
Yeah, look, it's a really hard one. I think a lot of my experience, even somewhat recently, has been either second line immunotherapy, so that's second line immunotherapy, or they're at a point where they don't really have that option. I think, I've seen people have cis and a little bit of carbo. I think it's boss dependent, but I do wonder whether they're choosing carbo because it's a tiny bit nicer as a drug. You've got to think of things like, you know, ototoxicity, those sorts of things, or other sort of things that might prohibit them from cisplatin. Um, but ultimately, so just this is in the context of our discussion, but second line, you can, if you've had chemo, you can use nivolumab from memory. I've seen that happen in the second line setting, but this is obviously, we're talking about first line treatment when we're going to talk about immunotherapy. But most of the time, if they're fit enough, they're going to get immunotherapy these days. There's going to be some rare contraindications, and it might be due to severe immunological, rheumatological condition that's uncontrolled. Maybe that's something that you'd be thinking of. But even then, they're starting to treat that cohort as well and kind of manage those toxicities. But ultimately, if you can't manage the immunotherapy, you're not going to be able to manage the chemotherapy.
Mm. Well, I think that segues quite nicely into what you're going to talk about.
I
So,
know.
so we've got a very low bar that we have to clear, an important bar, but a very low bar to clear. And so, why don't you talk to us about the Checkmate study?
Yeah, thanks, Mikey. So, this is a game changing study. We talk about game changers, pivotal trials, practice changing trials. They all mean the same thing. There's something that's actually slightly worthwhile to use. But this was the first line ipi-nivo, ipilimumab plus nivolumab in unresectable malignant pleural mesothelioma. It was a multiple randomized open label phase 3 trial. Now, this was by Paul Bass, and I think would have been published in 2021 from memory. And a little bit of further background just on mesothelioma. So we were talking previously about resectability. Generally, it's pretty much most people who are diagnosed are unresectable, and when we look at those that survive 5 years or below or above, that's less than 10%. So that's a poor 5 year survival. Like, even from a general cancer perspective, that's really poor. What we also know is that worse prognosis is reported in the non-epithelial histology versus the epithelial histology, and that will come into discussion when we actually look at immunotherapy as well. Now, looking at this specific trial and the method. So this was, as I said before, it was an open label randomized phase 3 trial, 103 hospitals, 21 countries. These are patients, they weren't amenable to curative treatment, meaning surgery with or without chemo, and had a good performance status of 0 or 1. Now, they had to have measurable disease. Again, we've spoken that in previous podcasts, but essentially we have to be able to identify a lesion and then follow it over time. Otherwise, we just don't know if the drugs are actually going to work. Now, exclusion criteria include brain metastases unless they were resected or treated. They've got an autoimmune disease. Again, that might be changing now because there's a lot of research going into if we can treat that kind of cohort of patients. Inadequate hematological, renal, hepatic function, known HIV infections, or interstitial lung disease. So fibrosis or lung fibrosis or scarring of the lung is one of those potential toxicities of immunotherapy that you've got to be really careful about, because let's say you help their cancer and then they can't breathe, that's not a particularly good outcome. So patients were enrolled and randomized 1-to-1, and then they were stratified based on their sex, their histology subtype, and they were given nivolumab plus ipilimumab or platinum plus pemetrexed, as Mikey spoke about before. Now, patients are pre-treated with folic acid and vitamin B12 in the pemetrexed cohort. That's just kind of the standard because it's a antifolate metabolite as well. But look, I'm probably just going to skip through and talk a little bit about the demographics and the results, because I think that's the important thing, and that's the stuff that we want to talk about on this podcast. Predominantly men. I guess that's the first thing to say. So about 77% in each cohort arm was men. Now, reason for that is going back the last 50 or 60 years, Men obviously dominated the industries where asbestosis or asbestos was prevalent. But again, people who clean the clothes got exposed to the dust could also develop asbestosis and mesothelioma. So that's why there's still about a quarter are women as well. Predominantly the patients collected from across the world, but predominantly Europe. Most had an ECOG performance status of 1, which is always quite interesting, actually. So I wonder if this was people who, they've been diagnosed, but they had other issues, all those sorts of things. And then looking at the histology subtypes, so 3/4 were epithelioid, and then about a quarter were non-epithelioid, with about 12% of those being sarcomatoid, and then mixed or kind of just, I guess, other types. Predominantly, at least half of each cohort was stage 4 metastatic disease. Very few had received systemic therapy, which is interesting. And that's probably just based on the fact of they were diagnosed, this trial had opened, you know, the existing data was so poor that they wanted something that was a little bit nice. So about 10% of the ipi-nivo group had radiotherapy predominant before that, and then less than 1% had had any systemic therapy. They did quantify the PDL1 status, and probably 80% had greater than 1%. But Mikey, from my memory, I don't think we will talk about PD1, but I think in this trial it wasn't powered, meaning we don't actually know if those that had a high PD1 sort of represents a better outcome when you look at immunotherapy versus those that had, I guess, less than 1%.
Yeah.
Now, oh, go on.
Oh no, I was just going to say I think that's this study does raise a few questions as well about who gets what and who benefits most from what, which I'm sure you'll go into.
Yeah, I will go into it. And this is why I actually really like this study, because it just shows that we have so much more to dig out of predictors and how can we tell if someone's going to respond to treatment. So patients were collected or recruited between 2016 and 2018, about 300 in each group, at the pre-specified interim analysis. So that's database lock. So when they're kind of stopped, that pre-specified analysis, the median follow-up time for overall survival was 29.7 months, with a minimum of 22. I think it was minimum of 22.1 months. Now, what I did forget to say to our listeners is that the primary endpoint was overall survival. It's always important to know what the study is looking for, and the secondary endpoint is progression-free survival, objective response rate, and all those sort of other things that we're always very much interested in. This is a bit of a sad statistic, but only 2% of the 300 patients in the intervention arm who received treatment remained on treatment. So what this means is that predominantly most of them had progressed, but that doesn't mean that this trial was a failure. What it means is that mesothelioma is really difficult to treat. I think 20% was due to toxicity. So nivolumab is generally pretty well tolerated, but ipilimumab, especially if you've already got challenges, can be hard. And you can get the toxicities that Michael's spoken about in previous studies, which I'll also sort of talk about a little bit as well. Overall survival, and this is interesting. So we've got 3 Kaplan-Meier curves, and look, we'll leave the link for the trial in the information, but overall survival in all randomized patients. So what we found was 18.1 months in the intervention arm and 14.1 months in the chemotherapy arm. The hazard ratio for that was 0.74%, which was statistically significant, showing that at least a 25% better overall survival, I know that's a crude way of talking about it, than the traditional therapy. Then we broke it down, and we broke it down into, if you might remember, there was the epithelioid and the non-epithelioid tumor histology. And this is where things get a little bit more interesting. So in the epithelioid histology, the median overall survival for the intervention arm, again, ipilimumab plus nivolumab, was 18.7 months, and the chemotherapy group was 16.5 months. So couple of months difference, but still just, and this actually, apologies, this actually wasn't statistically significant. So while the hazard ratio is 0.86, it did cross that line of sort of 1 with a confidence interval between 0.69 and 1.08. But this is where what I love, right? So then you look at the non-epithelioid histology, and I think non-epithelioid histology predominantly has terrible response to chemotherapy. Would you agree, Michael?
I would agree with that, Josh. I mean, it was the group that I think both in the original 2003 trial, but also just in clinical practice, it was known to be a poor prognostic marker. If you had sarcomatoid or non-epithelioid mesothelioma, and all you had was chemo, you were almost certainly going to do a lot worse.
That's it, right? So I was actually going to answer for you. So thank you for chiming in. But the median overall survival, while the nivolumab and ipilimumab was pretty similar to both cohorts, being 18.1 months, the chemotherapy arm was 8.8 months. So that's a year. You get a year extra in your median overall survival with a hazard ratio of 0.46, which is fantastic and statistically significant as well. One of the things you might be wondering is like, so how long am I going to give treatment for? So they were actually given immunotherapy until disease progression, unacceptable toxicity, or for 2 years in the immunotherapy arm. And they were only given 6 cycles of the cis or carbo plus pemetrexed. So, 6 by 3, that's 18 weeks. That's like 4.5 months. So that's the overall survival, which I thought was quite this is a treatment option for a historically terrible response to chemotherapy. Looking at the forest plot as well, people with sort of stage 3 and 4 cancer did sort of show statistical significance and response. Portion of patients with a response of at least 1 year or 2 years. So at 2 years, you still had 32% who had a response at that 2-year mark. Right? So that's
Which
great.
is
Whereas
great.
a chemotherapy arm was 8%, which is abysmal. Not I guess when we say abysmal, some people still do benefit from chemo, but it's also like if there's something that's going to give her a better benefit, we will. Next, to talk about toxicities, we would talk about this, I think, every podcast, but most common: diarrhea, pruritus, rash, fatigue, hypothyroidism. I actually find, if they don't get the colitis or, the inflammation of the bowel, I find with a lot of my patients, fatigue is actually a really common real world outcome for immunotherapy. Would you agree, Michael?
I would say it's in some ways the most common in that, yeah, it is the one that is the hardest to pin on immunotherapy. But it's the one I see most commonly. It's the one I've told patients is the most common.
That's it. And the little description I always use with my patients is like, imagine you have a new iPhone and it lasts a day and a half for its charge, or an Android if you're on that side of the fence, and then you go
We don't
3 years
discriminate.
later. I'm not discriminate. You can have whatever phone you want, just something with a battery in it. And then you go 3 years down the track, right? And then it's like, oh, it's just lasting 8 hours. That's exactly what it feels like when you're on immunotherapy, is that, you kind of feel really drained. It's like working an 80-hour week and you're like, oh my goodness, what's happened? And look, we always check people's cortisols and thyroid tests, which can be sort of some other endocrinological side effects from our immunotherapy. But I find my patients personally, fatigue is quite a common thing, especially if these guys are young. I guess to summarize this trial is that it met a primary endpoint, which was improved overall survival with ipilimumab and nivolumab versus chemo at the pre-specified interim analysis. The 2-year overall survival rates was 41% and 27%. Survival benefit was observed regardless of histology, although I think statistical significance was also, I guess we have to question that in that one cohort. The thing is, though, is that we've seen a benefit, which means this is really the new standard of care if it's available. I think that's really the baseline here.
What was really driving the overall benefit was the phenomenal benefit in those with non-epithelioid. Ipi-Nivo just blew chemo out of the water in non-epithelioid.
I did actually mention that when I was talking about it. But hopefully people were listening to me.
Sorry, I just wasn't listening.
That's fine. You deserve not to. You don't have to listen to me. But yeah. So when I was talking previously about whether it's statistically significant and when it's not statistically significant, it means that the intervention and control arms are relatively similar. But again, I guess my thing is this, Mikey, is like if it, immunotherapy, sure, it's more expensive, but I find people just tolerate it better than chemo.
I mean, it's in Australia at least. It's approved for mesothelioma, so the cost to the consumer is
Zero
low
dollar
if
dues.
absence. Yeah, $0 dues. That's the currency we use in Australia.
But I think in summary, I might finish it off because I got the more exciting trial this time. Is that mesothelioma is a very difficult cancer to treat, and there's been limited development in the last couple of decades. But Ipi Nuvo stands to be the new standard of care in the non-epithelioid subtypes, where chemotherapy historically has had really poor outcomes. Now, when it comes to the epithelioid subtypes, I guess the debate, and it's probably a discussion with the specialist at hand, whether you're going to trial the immuno or the non-immunotherapy, being that of chemotherapy. But I think there's enough data to really say you could choose either, and it wouldn't be a wrong answer.
As you say, it does come down to what you think is best for the patient. If it's someone who you think can take immunotherapy, then immunotherapy. If not, then you have chemo as a bit of a backup.
Yeah, and I think the context of that is single agent immunotherapy is very well tolerated, but ipilimumab can be difficult.
Yeah, definitely. All right, well, we might leave that one there. Thank you, Josh, for a stimulating conversation on mesothelioma. It's always grim reading, but important. Hopefully, less important as time goes on.
Exactly. And stay tuned for our next episode coming to a podcast place near you.
Wherever you get your podcasts, absolutely. All right. Well, look, thank you very much for listening. And thank you, Josh. We'll see you next time. Goodbye.
See you then. Bye.